Hello, good morning. Good morning, everyone. Am I live? Am I visible? Give me a thumbs up in the chat box if I'm clearly visible, audible to you guys. Yes? Anyone from the audience? Give me a minute to confirm. If I'm clearly visible, audible, I will start the session ahead in next few seconds. Give me a minute. Okay, I guess it's working. So, I welcome you all for today's session. A very good morning to all of you. A refreshing morning, a new morning, right? So, today I am going to teach you an important topic from pathology, from systemic pathology. On huge demand of students, I am going to teach you this topic, and today I am going to teach you inflammatory bowel diseases. So many students requested they can't understand the differences between UC and CD. What is the basic difference? What is the pathology? How grossly they differ? How microscopically they differ? So that's why I have launched this session. So today I am going to teach you inflammatory bowel disease, right? So without wasting any further time, give me a minute. Let me start inflammatory bowel disease. Let me see if I can see your chat. Yes, I can see. So, what is inflammatory bowel disease? As the name indicates, it's bowel. So, it is a disease of the intestine, either of the large intestine, either of the small intestine, or both can be involved. And there is inflammation in the bowel. So, the term inflammatory bowel disease is basically used for two distinct pathologies, which are known as ulcerative colitis and Crohn's disease. Crohn's disease is usually known as CD and ulcerative colitis is usually known as UC. So both of them are inflammatory bowel disease, that is known as IBD. Now, what is the basic difference between them? How to understand them? Grossly, how the two differ? Microscopically, how the two differ, and how to diagnose them separately, right? So let me teach you both types of inflammatory bowel disease. We will see their details one by one. Let's start with Crohn's disease first. Let me finish first Crohn's disease and then I will come on the second one, that is ulcerative colitis. So Crohn's disease, right? In this diagram you can see both. I guess you all can see this diagram. You have to understand this diagram. This side you can see Crohn's disease. This side you can see ulcerative colitis. In both the diagrams you can see the small as well as large intestine. Now you have to understand the starting point of the Crohn's disease. The starting point of the Crohn's disease is terminal ileum. Here I am marking that for you. Can you see? This is terminal ileum. It starts from terminal ileum, and on the contrary, the starting, so it is a junction of small and large intestine, you can say. The junction at which small and large intestine are meeting, that is the terminal ileum, right? That is the starting point of Crohn's disease. And in ulcerative colitis, the starting point is the rectum, the end point of the large colon. Here you can see the difference in the starting point of the two type of diseases. So here we are discussing the Crohn's disease. You got it? Osama, Jahangir, you got it? Yes. So Crohn's disease, it's starting from terminal ileum. The first difference you can see. On the contrary, when I teach you ulcerative colitis, I will teach you it is starting from the rectum. Number one. The second thing you can see in the two diagrams, Crohn's disease, there are skip areas. What do you mean by skip areas? So I guess you can see this area is involved, but this complete is not involved. Again, this is involved, then not involved. This is involved, not involved. So you know there is alternate involved, uninvolved areas. It is known as skip. You know, skip areas are there. So in Crohn's disease, it is not a disease of continuity. So small areas involved, then areas uninvolved, then areas involved, then uninvolved. You can see in this diagram the red one are the involved one and the normal pink, they are uninvolved. So you can see skip areas are present in Crohn's disease. On the contrary, you can see ulcerative colitis, it is starting from rectum, number one. And you can see it is continuous involved. There is no skip area. So here involvement is continuous. So here skip areas are absent. So you have to understand back to back the differences between Crohn's disease and ulcerative colitis. You got it? So in Crohn's disease, the skip areas are present. In ulcerative colitis, skip areas are not present. The continuous involvement is there. In Crohn's disease, the starting point is the terminal ileum. And in ulcerative colitis, the starting point is the rectum. I guess everyone got it. Yes? Sachin? Yes? Osama, you got it? Okay. So the same thing is written here. In Crohn's disease, it is starting from terminal ileum and it extends backward into the cecum and sometimes an ascending colon. And skip areas are present. So let me tell you 6 points in the gross in Crohn's disease and then we will discuss ulcerative colitis. Let me discuss Crohn's disease. Currently, I am teaching you Crohn's disease in detail, the gross of the Crohn's disease. So I have already explained you what do you mean by skip areas. Skip areas is bowel involved with intervening uninvolved. So there is alternating area, involved, uninvolved, involved, uninvolved. So this is known as skip area, right? Now the area which is involved, that portion of the bowel, that portion of the intestine become thick and hard like a pipe. You know, pipe, it is known as hose pipe. You got my point? So can you see in Crohn's disease, this area is involved, this area is involved, this area is involved, this area, and remaining is not involved. So I can say the skip areas are present. On the contrary, in ulcerative colitis, I can't see any skip areas. It is starting from the rectum and in continuity. So skip areas absent means continuous involvement is present. And here skip present, continuous absent. You can see back-to-back differences. Number one. And number two, due to the involvement, here the bowel become thick, hard. It is known as hose pipe. This type of bowel is known as hose pipe. Actually, the lumen of the bowel get narrowed here. The lumen is narrow. If you see the lumen, it is a narrow lumen from inside because of the involvement of the bowel. But if you see in ulcerative colitis, the lumen, here the lumen is wide. The bowel get dilated, not narrowed. Here the lumen will get wide because the bowel get dilated. It also looks like a pipe, but a dilated pipe. So such pipe is known as garden pipe. So both are looking like a pipe, but this one is a narrow pipe. The narrow pipe is known as hose pipe. And this one is a dilated pipe. The dilated pipe is known as garden pipe. Everyone give me a thumbs up. I'm trying hard. So see the differences between the two. Actually, the differences are important. If you understand them once, now you will never forget. So what is hose pipe? Hose pipe is such a pipe in which the lumen is narrow. And what is garden pipe? Garden pipe is such a pipe in which the lumen is wide. So we can correlate the two type of the pipes with the two type of diseases. In Crohn's disease, the lumen get narrowed. It is known as hose pipe appearance. And in ulcerative colitis, the lumen get wide. That's why it is known as garden pipe appearance. Give me a thumbs up. Vikram, Sachin, Osama, Jahangir. Give me a thumbs up. I can't see others' name. Right? Can we go ahead? Same you can see here also. Can you see? Can you appreciate? Can you say this is Crohn's disease? Can you say this is ulcerative colitis? Yes. What can you notice here? You can notice here skip areas are there. You can see clearly skip areas are present, right? And in ulcerative colitis, you can see the continuous involvement. It's not skip, it's continuous involvement is present. I guess everyone can appreciate the change, right? So this is how you have to see. You have to say the starting point. Here the starting point is terminal ileum. Here the starting point is rectum. You have to say whether it is skip involvement or continuous involvement. Number two. Number three, you have to correlate the lumen. Lumen is narrowed or wide. If it is narrowed, it is hose pipe in Crohn's disease. And if it is wide, it is known as garden pipe in ulcerative colitis. So till now we have learned 3 points, right? You have to understand all 3 points. The starting point, skip areas and hose pipe, right? Now the next point, I'm teaching you CD currently, right? And next we will see the UC, right? So this is Crohn's disease. If you cut the lumen and open the intestine from inside, so you can see this is the cut portion. I have already cut. You can see this diagram. I have cut. I have with a scissor, I have opened the terminal ileum and opened it from inside. So can you see this portion is terminal ileum. This is colon. This is the junction of the ileum and the colon, the starting point of the colon. So inside that I can see the ulcers. I can see the ulcers. What is the shape of the ulcers? The shape of the ulcers is like a snakes. You know, small snakes. It is known as serpentiginous ulcer. So serpentiginous ulcers are present. Give me a thumbs up. What type of ulcers are present? I am talking about CD currently. So here serpentiginous ulcers are present, right? And these ulcers are, the shape is like a snake, but they are very deep. You know, there are 4 layers in the intestine: mucosa, submucosa, musculatus propria, and adventitia, serosa. So ulcers start from the, yesterday I taught you the definition of the ulcer, the breach in the mucosa. So it starts from the mucosa, go deep, ulcer get converted into fissures. So they become deep, they become fissure. You got my point? So you can see the ulcers. So let me draw a portion of intestine for you to explain you something. I want to explain you here something. So let me draw, this is a portion of small intestine, right? Or large intestine, whatever. Here I'm teaching you CD right now. This is CD. So here the ulcers are serpentiginous, right? So they are snake shaped, right? And initially they are superficial, but they go deep, deeper, and they can involve all 4 layers. They start from mucosa. They start from the mucosa here, but they go deeper into submucosa, musculus propria, and serosa. They go deeper, right? Now what I want to teach you here, the remaining intestine between 2 ulcers. between any two ulcers, the remaining intestine swelled up. The remaining uninvolved, what I am saying, please mind my words. The remaining uninvolved intestine swells up between the two ulcers. It swells up. So it gives a cobblestone appearance. You know, the remaining surviving mucosa is swelled up between two ulcers. It gives a cobalt. What do you mean by cobblestone? Let me tell you. This appearance is known as cobblestone. This is cobblestone. These stones, you know, small stones hote hain. Have you seen it? These are known as cobblestone. So actually the intestine is looking like that. Why it is looking like that? The stones are the swollen mucosa which is uninvolved. But between the stones, if you can notice the fissure, these are the ulcers, the serpentiginous ulcer which go deep. You got my point? So here you can see these are the deep ulcers, the deep fissures, and the uninvolved mucosa swells up. So actually the stones is the uninvolved mucosa. Very few students can understand in depth. You got my point? Yes, Osama, Ram, Vikram, Sachin, yes. You got it? So what is it? You can compare. You can compare the normal intestine. You can see Crohn's disease intestine. See the change. See the cobblestone appearance. See the uninvolved mucosa, how it swelled up. How it swelled up. And between the two swelled up, there is a deep fissure. The deep fissure or the ulcer. So this typical appearance is known as cobblestone appearance, right? See again the same diagram I have drawn. This is cobblestone. This is endoscopic appearance. So you are a doctor now. Whenever patient will complain you GIT related complaints, you will do an endoscopy. So actually endoscopy is colonoscopy here. So you are doing endoscopy. On the endoscopy, this typical appearance you are finding. So looking at the endoscopy, you can make a straightforward diagnosis. It is a typical case of CD, because on endoscopy you are getting typical cobblestone appearance. In the cobblestone appearance, again I am repeating, you should know what is a stone. You should know what is a stone, and between the stones, what is this deep fissure? So the deep fissure is the ulcer, and actually the stones are the surviving mucosa which swells up. So actually again you can see this is the gross. If I cut the intestine, it looks from inside like this. So it is the gross, cobblestone appearance. I guess everyone got it? Everyone got it? So there are serpentiginous ulcer inside which cobblestone appearance is there, right? The next point, the ulcer sometimes become very deep and they become form the fistula and the sinus tract. They become very deep, very deep. So they become very deep, they form adhesions, they form fistula, they form tracts. So again, I would like to draw the intestine. This is the intestine. This is the intestine. The various loops of intestine. So here also we have ulcers. Here also we have ulcers, right? So actually between the ulcers, adhesions takes place between various loops. So adhesions are there, number one. Now in Crohn's disease, we are talking everything about the Crohn's disease. Adhesions are there. The ulcer become deep. They convert into fistula. They convert into sinus. Right, they become deeper, right? So initially they are ulcer, but once they become deeper, they convert into fistula and sinuses. So fistula, sinuses, deep ulcer, serpentiginous ulcer, everything is a feature of CD. Adhesions, it is a feature of CD. In UC, nothing will be present like this. I will tell you everything what about the UC, right? And sometimes the strictures are there. You know what is stricture? Please appreciate this portion. I have told you now the lumen become narrow here. I told you initially, that's why it is known as hose pipe. A pipe with a lumen narrow, right? Hose pipe, a pipe with a lumen which is narrow. So can you appreciate this portion? This portion is very narrow because this portion is involved and the remaining are uninvolved, skip areas, right? So the involved portion become very narrow. It results in strictures. So strictures are present in CD but not in UC. In UC, the lumen become dilated, on the contrary, not constricted. You got my point? Give me a thumbs up. The next point, multiple granulomas are there, non-caseating. These are non-caseating. In tuberculosis, we also have granuloma. But in tuberculosis, we have caseating granulomas. Here, caseating necrosis is not there, but granulomas are there. So, complete intestine, multiple granulomas. If you feel now, we can't see granulomas actually. But if you feel hard nodules are there. All of them are granulomas. They are to be felt. So, these are the gross findings. Now, let me come on the microscopy. Before that, I would like to revise gross of CD. Can you help me to revise the gross of CD? Ram. Can you help me? Osama. Yes. Vikram. Sachin. Others. Dr. Darnashi. Anyone? Please, can you help me with the points? Number one. Tell me the starting point. From which point CD starts in the colon? Tell me the starting point. Number one. Who will tell me? Number two. You tell me whether it is continuous involvement or skip involvement. The starting point, yes, ileum. To be exact, Priyanshi, say terminal ileum. The junction of the small and large intestine, the terminal ileum, the best answer. Yes. So the starting point is terminal ileum. Very good. Number 2, tell me whether it is continuous or skip. So everyone knows it's skip involvement. Continuous is not there, it's skip involvement. Number 3, tell me the shape of the ulcers. Ulcers are there. We all know ulcers are present. But what is the shape of the ulcers? Everyone? Yes? Yes, Priyanshi, Sachin, anyone? What is the shape of the ulcers? Dreamer, what is the shape of the ulcers? It's snake shaped. It is known as serpentigenous. Serpentine. Yes, very good, Ram. Very good. It's serpentine ulcers. Now the ulcers become deep. So ulcers become convert into what? Ulcers become convert into fissures. Number 1, fistula. Number 2, and sometimes sinus tract. Number 3. So ulcers become deep. They convert into fissure, fistula, and sinus. So fissure present in CD, fistula present in CD, sinus present in CD, and sometimes between the ulcers adhesions are formed between adjacent loops of intestine. So it is known as adhesions. Adhesions are present in CD. Everything will be absent in UC. These all are present in CD. Now between two ulcers, the surviving mucosa, the uninvolved mucosa swells up. It gives what appearance? The typical appearance known as, yes, the typical appearance known as Cobblestone appearance. Cobblestone appearance means the swelled up mucosa can be seen with the help of the, it looks like a stone. So these all points you have to, and what happens to the lumen in CD? In CD, the lumen of the intestine narrows or widens. I'm giving you two options. Does the lumen narrows or does the lumen widens in CD? Yes, the lumen of the intestine narrows. Because of the narrow lumen, it is giving appearance of stricture. So stricture are present in CD but not in UC, because in UC the lumen dilates, not narrows. Here strictures are present and it gives a typical appearance. Yes, Padmavati, it is hose pipe. I want to hear this name, hose pipe. A pipe with narrow lumen is hose pipe and a pipe with widened lumen is garden pipe. So garden pipe will be seen in UC, but here it's you know, it's hose pipe in CD. So these are the points in gross you have to mug up, or you have to learn, you have to understand. I have shown diagrams on each and every point. Can I move ahead? So after the gross, we would like to discuss the microscopy of CD now. Everyone give me a thumbs up. Yes? You know all these points? Write down 1, 2, 3, 4, 5, 6 and draw the diagrams to explain all these. Each point have a diagram. The last one I forgot, granulomas are present. Write down the next. Granulomas. Multiple granulomas which are non-case eating, they are also present. So basically let me summarize. In CD, in Crohn's disease, number 1, fissures present, fistula present, sinus present, granuloma present, adhesions present, stricture present. These all will be absent in UC, right? Ulcers wahan pe bhi honge, but here ulcers are deep. In UC the ulcers will be superficial. Here skip areas are present. In UC skip areas is not there, continuous involvement is there. So everything will be opposite there. Here hose pipe appearance is there, there garden pipe appearance is there. So everything will be opposite there. You got my point? So that is the gross. After the gross, let me discuss the microscopy of CD, then we will move to UC. Okay? Microscopically, you have to learn 4 points. Everything is visible in this diagram. Don't learn the 4 points. All the 4 points I will show you this in this diagram. Can you see this diagram? How many layers are there in intestine? There are 4 layers. Mucosa, submucosa, muscularis propria and serosa. Say yes. Yes. So see the mucosa. Let me draw the mucosa. Start with mucosa. So I'm drawing mucosa. Oh my god. Mucosa is discontinuous here. And again continuing from here. It's like continuous everywhere till end, I guess. No, it's not continuous till end. I got discontinuity again here. Right. So basically I got 2 ulcers. So discontinuity in mucosa, it is an ulcer here and it is an ulcer here. So wherever you wish, you can draw multiple ulcers. So I got 2 ulcers. What is the ulcer? A breach in mucosa. I got 2. In this diagram, I got 2. You can get any number given in the book. Yes. Now see, yes, see Osama. See, the ulcer is deep. It is going deep from the mucosa. It is going to submucosa, maybe up to muscularis propria. You can see the breach here. You can see the breach here also. So basically the ulcers are deep, which are converting into fissures. So say first there are ulcers and they convert into deep fissures. Number 1. Can you see here? Yes, you can see as well as you can draw. You can draw, right? After that, number 2, you can see what the next finding I can notice here. In the submucosa, what is this thing? In the submucosa, I am drawing a circle here. What is this? What is this? These 2 circles. What are these 2 things? If you notice, you will see, ma'am, inside this there is a giant cells and multiple epithelioid cells. So a collection of giant and epithelioid cell is a granuloma, but no necrosis. Here also giant cell and multiple epithelioid cells. So basically these are granulomas. So we find the deep ulcers, we find the fissures, we find the non-caseating granulomas. Say yes. Can you see the granulomas? Yes. This one is spare patches. It is a normal finding. A collection of lymphocyte is normal finding in intestine. That is known as spare patches. This is not abnormal. But a collection of epithelioid cells and giant cell is a granuloma. Right? I can see granuloma but without necrosis. So I will say non-caseating granuloma is a finding. Right? Number 3. You can see all 4 layers. Listen everyone here. You can see all 4 layers. You can see the mucosa, submucosa. This one is muscularis propria. This one. And behind that the last one is the serosa. Right? You can see all 4 layers. In all 4 layers I can find lymphocytes. Lymphocytes and neutrophils. Basically lymphocytes. Not neutrophils, I'm sorry. All of them are lymphocytes. So I can find the lymphocytes in submucosa, in muscularis propria and serosa. So inflammation is present. But in which layer? All 4 layers. So I will use the word transmural. What do you mean by trans? Trans का मतलब होता है all the layers. Mural, all 4 layers में mononuclear inflammation. Mononuclear मतलब it is not neutrophil. Neutrophils are polymorphonuclear cells. The mononuclear is the lymphocyte. So I am getting lymphocytes in all 4 layers. But say this in a catchy language. Say mononuclear cell transmural inflammation. In pathology you have to say like this. And apart from that, in the background you can see the edema. That's it. The 4 findings. Can you tell me what are the 4 findings? Initially the ulcers are there. The ulcers convert into deep fissure. They are deep. They convert into fissures into all 4 layers. Number 1. Number 2, the granulomas are there but they are non-caseating. Number 2. Number 3, the inflammation is present in all 4 layers. That's why known as transmural inflammation, right? And it is made up of lymphocytes basically, no neutrophils, right? That's why mononuclear inflammation. And the last one, edema is there. Can you enumerate the 4 findings in this diagram? Don't learn, enumerate them. If you are a second prof student, you should be able to draw it. And if you have already passed second prof now, just enumerate it to identify an IBQ. This IBQ can come in your exam. What are the 4 findings? Come on. 4 microscopic findings of CD. Can you tell me? Anyone help me? Priyanshi, Osama, Sachin, Padmavati, Ram, anyone would like to help me? The 4 findings. Number 1, the ulcers are there. Ulcers is deep breach in mucosa. They get into deep fissures. They get convert into deep fissures gradually, right? Number 2, granulomas are there, but granulomas are non-caseating. Number 3, inflammation is there. Now write 2 things of the inflammation. 2 things for the inflammation. Number 1, it is transmural. Transmural, it involves all 4 layers. Now this transmural is typical of CD. In UC, inflammation is not transmural, only in superficial layer, not in deep layers, right? So in UC, I will show you the diagram now. You will get inflammation only in mucosa and submucosa. There is no inflammation in muscularis propria and serosa. Here inflammation in all 4 layers, which is typical of CD, right? And inflammation is mononuclear. That is basically lymphocytes are there. In contrast to UC, where inflammation will have neutrophils. यहाँ पे mononuclear है, वहाँ पे neutrophils होंगे. Both things will be opposite in UC. You got my point? And last one is edema. Last one is edema. Give me a thumbs up. Come on. You got it? Can we move ahead? Okay. So I guess we are done with CD. You can see the diagrams, the various diagrams. These diagrams are from Robbins. You can see the transmural inflammation. If I zoom, you can see all of them are lymphocytes, right? And here you can see the granulomas. So these are the diagrams from the Robbins showing the same findings, right? The next point, if I take the blood sample of such a patient, I will get antibodies in the blood sample. Which antibodies? Actually, the patient with CD have an infection of a fungus. The name of the fungus is Saccharomycetes cerevisiae. This is the name of a fungus, actually a yeast. The antibodies are formed against the fungus. It is known as anti-Saccharomycetes antibody. So in a patient of CD, you will get these antibodies. That's all about CD. Let me pack CD. So we are done with CD. Let me start UC now. Can you first enumerate CD? Everything about CD. The 6 gross findings. 1, 2, 3, 4, 5, 6. And 4 microscopic findings. 1, 2, 3, 4. And 1 blood finding. In the blood you get antibodies, right? So serology findings. Only one type of antibody. So if you can enumerate all these, CD is packed. You can write everything about the CD. Can you do that for me? I will try. So in the gross, write down it starts with terminal ileum, right? Starting point. Then write skip areas are present, not continuous, right? Then write serpentigenous. serpentine ulcers are there, which convert into fissures, fistula, sinus, adhesions. Everything is due to ulcers, right? All are present, right? Granulomas are present. The next is granulomas. They are present. What was the next finding? Cobblestone appearance. You can understand. So I guess these are the gross findings, right? And the pipe, it's narrow lumen, which is known as hose pipe. Hose pipe. So these are the 6-7 points in the gross you have to mug up, right? In the microscopy, you understand only 4 points. Only 4 points. Number 1, initially ulcers are there which get converted into fissures. I have shown you in the diagram the deep ulcers, the fissures. Number 1. Number 2, granulomas are present, but they are non-causating. Number 3, inflammation is there, but inflammation is transmural, involving all 4 layers, and only lymphocytes are there. Mononuclear is there, no neutrophils. And last one is edema, right? In the blood, you get only one antibody. It is known as anti-saccharolytic cervicized antibody, which is a fungus. That's all. That's all. Yeah, string test. Ram, you are asking about the string test now. So as I've told you, yes, here strictures are present. Due to hosepipe appearance, that is known as string test. So if you do the barium enema, if you do a barium enema in this patient, you will get a stricture. The stricture there, that stricture on the barium is known as string test. So that's all about CD. So let me start the next one, UC. Any doubt in that? Any doubt in that? Just a second. Okay, why I am unable to write? Give me a minute. Okay, yes. So let me start with UC. Give me a thumbs up now. Right? Can I move ahead? The UC, the next type of IBD is UC. Now everything will be opposite, right? In UC, it starts with rectum, not with terminal ileum. The starting point is rectum. You all can notice the starting point is rectum, and the involvement is continuous. The second thing, you can see the involvement is continuous. There is no skip areas. Compare it with CD. The starting point is terminal ileum and skip areas are present here. Here there is no skip areas, the continuous involvement. Sometimes due to continuous involvement, it will move backward, backward, backward and involve the complete colon. Starting from rectum, it will move first to descending colon and then transverse colon and then ascending colon. So all the colons are involved. If all the colon is involved, it is known as pancolitis. Sometimes it leads to pancolitis. What after that? So it is starting from rectum, going to descending colon, going to transverse colon, going to ascending colon. After that, sometime it can move to ileum also, right? From the terminal ileum, it will enter in the ileum and start involving ileum in continuation only. So once it involves ileum, now it is known as backwash ileitis. Ileum is involved, but from the backward, पीछे से आया. You know, आगे से नहीं आया involve करने के लिए, पीछे से आया. It is known as backwash ileitis. So it starts with rectum. It will grow in continuation. It will involve complete rectum. When complete colon is involved, it is known as pancolitis. After colon, it can move into ileum and ileum can also be involved in severe cases. It is known as backwash ileitis. Give me a thumbs up. So start from rectum, move to pancolitis, then backwash ileitis. This is the progression of the disease, right? No skip areas, everything is continuous. Give me a thumbs up, right? Compare it. Can you compare? Yes, you can. Compare CD, it's skip areas. Compare UC, it's continuous, right? So initially rectum, then descending colon, then transverse colon, then ascending colon, and then ileum. So it is known as pancolitis followed by backward ileitis. I guess everyone got it. If everyone got it, give me a thumbs up. Let me tell you 4 or 5 points in the gross here. You already got its continuous involvement, right? If CD occurs now, the patient have symptoms continuously. But in UC, the symptoms are not continuous. It is remission and exacerbation. For few months or few days, patient have symptoms. For the next few days, patient don't have any symptoms. So exacerbation and remissions are common here. Here, the lumen get widened in contrast to CD where lumen get narrowed. So here lumen get widened. That's why it is known as garden hose pipe appearance or pipe stem appearance. It is a widened pipe. You got my point? Compare the two. Can you compare the two? This one is CD, I guess. This one is UC, I guess. You all can compare. So you can see the skip areas here. You can see the continuous involvement here. You can see here lumen is narrow. That's why known as hose pipe. Such a pipe is known as hose pipe. And here lumen is widened. So such a pipe is either known as garden pipe or it is known as pipe stem. Both is same. One and the same. I guess you got it, right? Here also ulcers are there, but the ulcers are superficial, never deep. No fissure, No fistula, no sinus. No, ulcers are superficial. I will show you in the diagram also. The ulcers are typically superficial in contrast to CD, where ulcers go deeper, deeper, deeper and convert into fistula, fissure and sinus. Here no fistula, no fissure, no sinus, no adhesion, because ulcers are not at all deep. They are just superficial. You got my point? So see here, the ulcers are superficial. Can you make out? Yes. You can make out the ulcers. They are very superficial. They are superficial. They are not deep. Not. So I am cutting the rectum and opening it to show you the ulcers. There I have cut the terminal ileum to show you the serpentigenous ulcer. Here also I am cutting you the rectum, not the terminal, because the starting point here is rectum. So you will get the ulcers in rectum. The ulcers are there, but the point is that the ulcers are very superficial, right? The ulcers are very superficial. Now again same thing. Between two adjacent ulcers, the normal mucosa swelled up. Here also the intervening intact mucosa swelled up and it looks like a polyp. It is known as pseudopolyp. Actually it is not a polyp. It swelled up. Can you see here? Okay, let me explain you. You can see here is a superficial ulcer. Between the superficial, this is also a superficial ulcer. So between the superficial ulcer, the normal mucosa just swelled up. Can you see the swelled up mucosa? The swelled up. So it looks like a polyp, but actually it's not polyp. So that's why it is known as pseudopolyp. And the same thing there in CD, it was known as cobblestone appearance. Here the same thing is known as pseudopolyp. So don't say cobblestone appearance here. Here say pseudopolyps are present. So pseudopolyps are typical finding of UC, not CD. Give me a thumbs up. And what is pseudopolyp? What is pseudopolyp? The intervening intact mucosa get inflamed and swelled. It looks like polyp but not a polyp. It is known as pseudopolyp. Give me a thumbs up. Come on, you got it. Padmavati, Priyanshi, Osama, Ram, others, Amir, you got it. So that is known as pseudopolyp. That is the meaning. See, if you open the rectum, sometimes you can get this picture. Come on endoscopy you can get this picture. You are getting multiple polyps. All of them are pseudopolyps. They are not real polyps. They are pseudopolyps. Actually, between two polyps, between two adjacent polyps, these are the superficial ulcers. So because of the ulcers, the intervening mucosa between adjacent ulcers swelled up. I guess I'm crystal clear in my concept, right? This is known as pseudopolyp, right? So the same image from the Robbins also, you can see the pseudopolyps. You can see the pseudopolyps, right? So these are the pseudopolyps, right? In severe cases, what happens? Due to the pseudopolyp, the complete colon, when pancolitis is there, the complete colon is involved and neuromuscular, it is just shut up. The colon stopped working. The colon just swells up. It is known as toxic megacolon. The complete colon just shut up. It is not working at all. It just swelled up. It is known as toxic megacolon and sometimes it can result in carcinoma. So UC can result in carcinoma, but CD can never be malignant. CD can never result in carcinoma. UC sometimes can result in carcinoma only in 1% cases. Only in 1% cases, UC can proceed to carcinoma of colon. After pancolitis, it can result in toxic megacolon. You can read the word megacolon. Megacolon means complete colon. Complete colon means pancolitis. I guess you can make it out. Give me a thumbs up. Give me a thumbs up. Now we have. So can you enumerate the gross finding of CD and UC? Can you enumerate the gross? Then we will compare the microscopy. Can you enumerate? Yes. Tell me the starting point here. Starting point here. The starting point here is terminal ileum and starting point here is rectum. Right? Everyone knows it. The next here we have skip areas present. Here we have continuous involvement, not skip areas. Right? The next point, what is the progression here? So here, okay, before coming to the ulcers, let me tell you, okay, here we have serpentine ulcers. Serpentine ulcers which become deep. After becoming deep, they convert into fissure, they convert into fistula, they convert into sinus and they convert into adhesions. Right? Here the ulcers are there, but they are not serpentine. The first thing, the ulcers are there, but the ulcers are very superficial. So no fissure, no fistula, no sinus tract and no adhesions. Everything is absent here. So what is the course here? Here after involvement of rectum, it will go in continuity. It will involve complete colon. The complete colon involvement is known as pancolitis. Pancolitis leads to toxic megacolon. Toxic megacolon. You got my point? And after that, it can involve the ileum also backward. It is known as backward ileitis. So backward ileitis is seen in UC. You have to take the words, right? Backward ileitis. You got my point? So these are the findings you should take in consideration. Now, one more important point we are going to write here. Between two ulcers, the intervening mucosa swells up in both. Right here, it gives cobblestone appearance. That appearance, cobblestone appearance, and here that appearance is known as pseudopolyp. You got my point? What is cobblestone and pseudopolyp? One and the same thing. Between two ulcers, the uninvolved mucosa swells up. So that appearance here, it is known as cobblestone. Here it is known as pseudopolyps. You got my point, right? The next is the lumen size. Lumen size is narrowed or widened. What is it? Is it narrowed or is it widened? In CD, the lumen is narrow. That's why known as hose pipe. And here the lumen is wide. That's why known as garden pipe. I guess you all got the difference. Am I missing something, or I have written all the differences between them? So that's how you have, yeah, granulomas. One more finding, granulomas. Granulomas are present. Non-caseating granulomas are a finding in CD, but not in UC. Now let's see the microscopic differences between them. So I've already taught you the microscopy of CD. Let me teach you the microscopy, the 4 features of microscopy of UC. Don't learn it. See in the diagram. I always prefer to teach you the things in the diagram, not in theory, right? Okay. Again, we will do the same thing. We will start with mucosa. We will see where is the mucosa discontinuous. So start with mucosa. Mucosa is continuous. I guess everywhere it is continuous. Till it is continuous. Oh, here it is discontinuous. So I got an ulcer. Right? So this ulcer, but this time this is an ulcer. This ulcer is very superficial. It is not going deep in contrast to CD. It is a superficial ulcer. Give me a thumbs up on this point. The ulcer is there. What is the ulcer? The discontinuation in mucosa. So mucosa is discontinuous, but submucosa, musculus propria, they are continuous. Ulcer is not going deep. It is not converting into fistula, fissure and sinus. No, it is not converting. Right? Number 1. Number 2, you can get inflammation here also. Number 2. But inflammation is present only in submucosa. You can see the inflammation here. The complete submucosa, the cells are there. All the cells are neutrophils. No. If you zoom it out, you can see the multilobated nucleus. They all are neutrophils. They are not lymphocytes. So inflammation is there, but inflammation is also superficial. It is not transmural involving all layers. I can't see inflammation in muscularis propria and serosa. No inflammation. Inflammation present only in mucosa and submucosa. Give me a thumbs up. So inflammation is superficial in contrast to CD, where inflammation is transmural. Give me a thumbs up. You got my point. Sometimes, you know what are crypts? These are known as crypts. You know, crypts and villi. I guess you can get it. The elevation is the villi and the depression is the crypt. So elevation is the villi and depression is the crypt. You got it? So see the depression. Where is the depression? I can see this is one of the depression. So at one of the crypt, I got a collection of neutrophil. Collection of neutrophil is the pus. You know what is pus? Pus is collection of neutrophil. Actually abscess. So it is known as crypt abscess. So in the crypts, abscess are present. वहाँ पे granuloma थे, यहाँ पे abscess है. So in that CD, I have shown you in the diagram granuloma. If you remember, you can find a collection of epithelioid cell. Here you are finding a collection of neutrophils. So there we find the granulomas. Here we are finding the abscess. What it is known as crypt abscess. What it is known as typical finding of UC. Crypt abscess. So in the crypt, where is the depression? Wherever the depression is there. On the depression, we are finding a collection of neutrophils. Right here only one is shown. So it is known as crypt abscess or cryptitis. Cryptitis. Itis means inflammation. So cryptitis or crypt inflammation is a feature. So these are the features of UC. So say ulcer is present, but it is superficial. Only mucosa, not in deep layers. Right, number 1. Number 2, crypt abscess is present, because of which cryptitis or crypt distortion is there. So all these findings are related to UC. Crypt abscess, cryptitis, crypt distortion. Right, वहाँ पे granulomas थे. Right, the second finding. And third finding, you will find the inflammation only superficial, not deep. Superficial inflammation. That's it. So these are the findings. So we are done with CD and UC. The cross, the microscopy. Everyone give me a thumbs up. Everyone give me a thumbs up. Come on. Do you have any doubt in that? I guess no. None of you have doubt. So see, I'm going to explain you something here. Can you see this is CD, this is UC. Everyone knows this point now. It is starting with terminal ileum. It is starting with rectum. I guess everyone knows it. And here skip areas are there. And here continuous involvement is there. ये तो सबको पता है. Now take a cross section here and take a cross section here. You can see the cross section. Come on, everyone here. See the cross section. See how many ulcers you can find. Here I can find one ulcer, 2 ulcer and 3 ulcer, but all the ulcers are deep, going in all 4. Can you notice the 4 layers? Here notice this is mucosa. Just below the mucosa there is submucosa, then musculus propria, then serosa. After serosa there is fat. And notice the same 4 layers here also. So the 4 layers are shown. If you zoom the diagram, you can see the 4 layers. Here see the ulcers are deep. And here if you see the ulcers are superficial. They are widened but superficial. They are wide. Width is zyada hai. But you know depth come hai. The depth is less. I guess I am able to explain you. I am trying hard. Give me a thumbs up. So see, the ulcers are deep in CD and the ulcers are superficial in UC. Give me a thumbs up. Yes, yes. So here the intervening mucosa swells up and it gives cobblestone between 2 ulcers. The intervening mucosa swells up. It gives cobblestone appearance. Here also the intervening mucosa between 2 ulcers swells up and it gives pseudopolyp appearance. I guess I am clear. Yes. So this is how you have to understand the things. Right. Can we move ahead? Can we? Have you appreciated it? Yes. Here also the same skip areas and continuous involvement bahut baar ho gaya. You can see it. Right. Now see back to back. Dono ka microscopic picture. The CD picture and the UC picture. Try to appreciate the 4 layers of the intestine in both of them. Try to appreciate. Try to appreciate. Here see the ulcer is deep. The ulcer is deep. And here see the ulcer is superficial. It is widened but superficial. First of all, see the ulcer. The second thing, see the inflammation. Here I can find inflammation in all 4 layers. And they all are lymphocytes, right? Here I can find inflammation only in submucosa, not in all 4 layers, and all of them are neutrophil. So see the inflammation. Here it is transmural, here it is superficial. Ulcer deep, converting into fistula, fissure, sinus. Ulcer is superficial. No fistula, no fissure, no sinus. Give me a thumbs up. Here transmural inflammation, lymphocyte. Here superficial inflammation, neutrophil. यहाँ पे lymphocyte है, वहाँ पे neutrophil है. यहाँ पे transmural all 4 layer, यहाँ पे superficial only mucosa, submucosa. You got my point. One special finding you can't miss. Here we can see granulomas and here we can see abscess. Compare it. Compare it. Granuloma is a collection of epithelioid cells and giant cells, and abscess is a collection of neutrophil. If you zoom out, you can make it out, and you can draw also in your exam. If you're a second prof student, you have to draw all these things in your exam. So this is granuloma but non-caseating granuloma, and here we can find crypt abscess, cryptitis, crypt distortion. Give me a thumbs up. So I guess these features are more important, and you can learn this, you can excel in your exam. Yes, can we do? Now the same comparative diagram from the Robbins, we will finish it up. You will tell me all the points. So this is CD, this is UC. Now you tell me the bowel involvement. Here it starts with terminal ileum and goes into the colon. Here it involves with colon and rarely it will come to the ileum, backwash ileitis. Here distribution is skip, here it is continuous. Strictures kahan pe present honge? Where the strictures will be present? In CD or UC? Strictures kahan honge? Where the strictures are present? Strictures are present in CD. They are absent in UC. Yes, yes, absolutely right. Yes. And the ball will become thick or thin. As I've told you, in Crohn's disease, the ball become thick. That's why the lumen is narrow. The wall of the intestine become thick. That's why lumen become narrow, hose pipe appearance. But on the contrary, in UC, the wall become thinned out. That's why it dilate and it gives garden pipe. So you have to learn the ball, whether it is thick or thin, right? Now tell me the next point, the inflammation. Inflammation in which layer? Here all 4 layers in CD, transmural, and here it is limited to mucosa, submucosa, that's it. So inflammation is transmural, it's superficial. Say yes. Tell me pseudopolyps kahan pe honge? UC mein ki CD mein? CD mein. The pseudopolyps are present, no I'm sorry, pseudopolyps are present in UC. Cobblestone appearance is present in CD. But in UC, it's pseudopolyps, right? Tell me about ulcers. Here ulcers are deep. Here ulcers are superficial but broad. Superficial but broad. The width is more. Say yes. Say yes. You tell me where is the granulomas? The granulomas, fistula, sinus, fissure, all these things are present in CD, but they all are absent in UC. Yes. Apart from which adhesions, due to adhesions there is serositis, fibrosis, all these things are present in CD but absent or mild in UC. You got my point? Malignant potential, malignant, one person get malignant, it happens only in UC, but there is no malignant potential in CD. Yes or no? Toxic megacolon. Toxic megacolon means involvement of complete colon, pseudopolyps. It happens in UC but not in CD. So say which things are present in UC, which things are present in CD. So this is how you have to differentiate them grossly and as well as microscopically. So I'm having few questions for you. You have to answer those questions. Can you tell me the answer of this question? Easy one. I guess it's easy. I guess it's easy. Everyone can answer. Skip granulomas are a feature of. The four options are in front of you. Is it UC, CD, Whipple's disease or Reiter? Now the question is only between A and B. Who will say? Who will say? So yes, Osama, Ram, Padmavati, everyone is saying the answer is CD. Yes, everyone agrees with them. The answer is CD. So skipping lesions as well as granulomas. Two things are asked in the question. So yes, both things occurs in CD. In CD we have skip lesion also and we have granulomas also. Both things fit here. So yes, everyone is right. Yes, Priyanshi, Padmavati, everyone. Osama is not A, it's B. I guess you got it. Yes, you realized your mistake. It's Crohn's disease. It's not ulcerative colitis. And answer is Crohn's disease. Can you tell me the next answer? Pseudopolyp are seen in. Pseudopolyp, not cobblestone appearance. I am asking about the pseudopolyp. So is it CD or UC? What you will say? CD or UC? Answer is A or B. What is the correct answer? Pseudopolyp. In one of them I told you cobblestone appearance. In one of them I told you pseudopolyp. So yes, everyone is right. Yes, Osama, Padmavati, Priyanshi, Ram, Chotu, everyone is right. So the correct answer is UC. So in UC you will find pseudopolyps. So actually between two adjacent ulcers, the non-involved intervening mucosa swelled up. It looks like polyp, but it is not a real polyp. That's why known as pseudopolyp, and it is a feature of UC. The same thing happens in CD also, but here we don't give the term pseudopolyp. We give the term cobblestone appearance. Right. So the correct answer here is B. Yes, Equira. Yes, Akhil. Everyone is right. Right. The next question is in front of you. Can you tell me the answer? Toxic megacolon is seen in. Read the options. Chronic non-specific ulcerative colitis or Crohn's disease or colonic diverticulosis or hematomatous polyp. What do you say? Toxic megacolon. So toxic megacolon is involvement of complete colon with pseudopolyps. So yes, you all are right. It happens in UC. It happens in ulcerative colitis. So this is how these are your PYQs from various exams. Can you tell me the next question? Skip involvement along with collar studded ulceration. Right? Along with, that's it. So collar stud ulceration means deep ulceration. Deeper. So skip involvement with deep ulceration. It is a feature of TB intestine, ulcerative colitis, intestinal amoeba or Crohn's disease. Now currently the answer is very easy for all of you. For all of you the answer is very easy because currently you have just read it, but once you will be reading all these diseases now you will get confused. So I am telling you, yes, the answer will be D. Yes, very good. The answer, I'm sorry. Collar stud, okay, skin involvement. It was not skipped. I misread it. Actually it is not skipped. It is skin involvement. Actually in ulcerative colitis along with intestine, the extraintestinal manifestation is skin involvement. The skin is also involved. I misread it. I'm sorry. It is not skip involvement. It is skin involvement. Yes. So skin involvement along with collar stud ulceration. Collar stud is superficial ulceration. So answer is B. I misread it. The answer is B, not D. You got it? Answer is B. Is it clear to you? The answer is B. Yes, yes, yes. You see my skin involvement. So can you tell me the next question? True about ulcerative colitis, all except. So what is not true about ulcerative colitis? What is false about ulcerative colitis? Can you tell me the answer? Read it. Rectum involvement, is it true or false? I guess it is true. Rectum involvement happens in ulcerative colitis. Pseudopolyp, is it true or false? It is also true. Pseudopolyps are formed in ulcerative colitis. Pancolitis, yes, it is also true. The complete colon gets involved. It is pancolitis. After that, backwash ileitis. But non-caginated granuloma, no. It is false. It is a feature of CD, not UC. So I will go with D. Yes, what about you? What about you? So yes, everyone will go with D. Ram, you are saying C or D? I guess the answer is D. Yes, pancolitis happens in UC. Yes, it's D. Right? Okay, the next one. Try this one. Try this one. All the best for this one. So which of the following is true about UC? Which of the following is true about UC? Tell me one of them is true. So about UC I am asking. It start with rectum and then involve the whole colon backward. Is it true? Or it involve colon only? Is it true? Skip lesions are seen. Is it true? Or ileum not involved? What is true? What is true? So Osama is saying A, Chotu is saying A, Ram is saying C. Ram, no Ram. Skip lesions are not seen in ulcerative colitis. They are seen in CD. I am asking what is true about ulcerative colitis. So ulcerative colitis, no, skip lesions are not seen. They are a feature of CD. Ileum not involved. It doesn't happen. Sometimes backwash ileitis happens. I told you, rarely in 1% cases, but it happens. So it starts from rectum, go backward, 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 involve the descending colon, transverse colon, ascending colon, and then after pancolitis, it moves to the ileum. It is known as backwash ileitis. So ileum not involved. This is not true. It involves. Okay, it involves only colon. No, it is also not true. Sometimes it involves ileum also. So I will go with A. I guess everyone will go with A. It's okay. It's okay. If you are doing mistake here now, Ram, I'm happy that you are doing the mistake here. If you do the mistake here now, you will not repeat the mistake, same mistake in exam. So whatever mistakes you want to do it here only. It is your practice session, right? So you will commit mistakes here, you will learn from your mistakes. Once you will do your mistake now, it will fit in your permanent memory ki nahi, I have done this question wrong and this time I have to do it right. Okay, so don't worry if you are doing the mistakes, stay happy. You are learning from it. That is more important. Anyways, the next question. Can you tell me anti-saccharocytic cervicitis antibodies are seen in? So it is a fungus. So antibodies against fungus are seen in CD, scleroderma, SLE or Sjogren. Yes? Where you can see? Yes, correct. So the correct answer here is A. Everyone is right. Yes, yes. Very good, very good. So thank you very much for being with me. And I would like to stop here. Yes, everyone is right. So if you still have any doubt, you can contact me on my personal contact number. It's 9833032948. If you have any study related doubt regarding your timetable, regarding patho, pharma, micro, PSM, any doubts, so you can ask me there. Don't forget to tell me your college name, your university and your probable exam dates. What exam you are targeting? You are targeting second prof exam or you are targeting some competitive exam or both. So kindly let me know. I can give you a tailored program for you. You know, a specific program just for you. So I can help you for that. So once you send me the message either on the WhatsApp or on Telegram, don't call, just send a message. So I will get back to you. Maybe it will take a day or two, but definitely I will get back to you as soon as I will get the time. Right, so you can contact me regarding study related doubts here. And yeah, on huge demand of students throughout the country, throughout the globe, many students are previously I taught PSM also in multiple batches, but currently last few months I'm not taking sessions on PSM. So many students are upset, especially those who are on third prof, who have already studied from me in the second prof and now they passed second prof with good gold medal distinction and now they move to the third prof. Now they demanded me that I should teach PSM also to them. So I'm launching a new free batch, the free batch for the PSM next week. So if you all are interested, you can attend the session of PSM also, right? Many of you may be third prof or final year or preparing for the competitive exam. If you are second prof and currently you are not interested for studying PSM from me, next year you will be interested. So you can give this information to your seniors at least. All those students who are in third prof. So in this free batch of PSM, I am going to cover all the short questions, all the long questions, important topics of PSM for their university exams, number one, and also for the competitive exam, all the MCQs will be covered. So both ways it is useful. So if you are preparing for your NEET PG, next, INICT, you know, USMLE, any of the competitive exam, PSM is a major subject. You guess at least 35 to 40 questions come from this subject, the only subject, right? So I'm going to take this complete batch for you all. Okay, so okay, done. So we can do that. So please help me in spreading this information to all your seniors, colleagues, batchmates, juniors, all the medicos who are interested to study PSM from me. You can send me a list of the topics of the PSM which you want to be launched in free sessions on YouTube. You are free to do that. So I will make a WhatsApp group. So I will send you a link, the WhatsApp link, the invite link. You on wherever you are all are there, I will send you on your WhatsApp group that the new link, and on the Telegram that is PSM by Dr. Priyanka. You have to share that link with all the medicos who are interested to study PSM from me. And the batch is starting from Monday, that is 3rd October, right? So from 3rd October I will send the schedule also. Thank you very much for being with me. Here in the comment section there is one more link given, that is the link tree. So I'm available on Instagram, on Telegram, on WhatsApp, on Facebook, everywhere you can join me. All the links are given there, on WhatsApp groups also, so you can join me wherever you want. Thank you very much. Study hard. All the best. Wishing you all the best for your exams. And today is a new day. Every new day brings new energy, new hopes. So study hard. Whatever is your target for today, now just finish it before sleeping. That is the only message I want to give you today. Bye bye. I'm ending this session.